Good afternoon and welcome. My name is Jerry Williams and I am the founder and president of MSU. We are coming to the end of Myositis Awareness Month with our theme, Myositis in Focus, and today we are putting dermatomyositis and itch in focus. Before we get started, I want to extend a special thank you to the team at Corbus Pharmaceuticals for once again partnering with us for a session with Dr. Werth. I just got back last night from visiting Corbus, along with Emily Fillmore and Heather Spadaccini, where we shared our experiences living with dermatomyositis and myositis, and in Heather's case, being a caregiver and friend for a myositis patient, as well as providing an overview of what we do here at MSU. We thank Corbus for the amazing opportunity they provided us. So we are once again honored to have Dr. Victoria Werth join us for new developments in the role of itch in dermatomyositis, and it's based on new research published in the British Journal of Dermatology. Dr. Victoria Werth is one of the dermatomyositis experts, and she is a professor of dermatology and medicine at the University of Pennsylvania School of Medicine and the chief of dermatology at the Philadelphia VMAC. She is an internist and dermatologist, and her practice is devoted to autoimmune skin diseases. We learned so much from Dr. Werth when she joined us for Rare Disease Day this year, and we thank her for joining us again right now.
So that people understand that this is a disease that needs to be looked at more carefully, and we need some different therapeutics to try to help. So to review a little bit, and I think you guys probably know this a lot, but there's certainly a muscle component with proximal extensor inflammatory myopathy that is usually symmetric. There's a characteristic skin eruption, which we talked about last time, and patients can either have what we call classic disease, where there's muscle or muscle with or without skin, and amyopathic, where the problems are really skin predominant. I would say that there are classics that get better in terms of the muscle and then convert more or less into a skin predominant problem. And that's every bit as much of a problem for some people as it is if they just had the skin disease to begin with. So in terms of the signs and symptoms, I think, again, we know that there's often erythema or papules over joints on the hands and over the elbows and knees at times. There's a photodistributed rash that can be on the V of the neck. There's a Shaw sign, a Holster sign, and also the Holster sign's on the upper thigh, on the lateral part of the upper thigh. The Shaw sign is redness and scaling on the upper back. And heliotrope is the redness or scaling that happens around the eyes and on the eyelids. Then there's poikiloderma, where the changes in color in the skin or texture can happen as a result of the inflammation that we see. There are changes in the nail folds with erythema and telangiectasias, and also the cuticles can be a little bit ragged. There's a sun sensitivity, which this time of year is a big issue, and this is a common time for people to have more problems with their skin and more itch, which is the bottom bullet there, pruritus. And that's what we're going to focus on today. So here you can see, again, the elements of erythema that you can see over the joints on the upper area in the hand, and then around the eyes, and then on the V of the neck. So a few years ago, we looked at what is the impact, or how many people have severe itch. And we had what we call a visual analog scale of 0 to 10. And so the average itch was a 3.8 for people who had dermatomyositis, relative to lupus, where it was actually quite a bit less. And you can see on the graph on the right-hand side that the darker bar is dermatomyositis, showing, again, worse itch than what we find in a very comparable skin disease or an autoimmune disease that can affect skin, namely lupus. So itch is really something in particular as a problem for dermatomyositis. So there are very few studies that evaluate the clinical characteristics and pathogenesis of itch in dermato, and we've been very interested to try to understand it better and to use it maybe even as a marker to see who and why people get better with new treatments as they come along. There are a limited number of patients, and there's not a lot of information about all of this, but that's what we're going to talk about today. So how many dermato patients itch? And this is going to be our first question. So we have a prospective database that has now enrolled, I would say we're actually up to about 260 patients, but at the time of this particular study, there were 218. And what this said, and we followed people longitudinally and looked at the amount of itch they had at their initial visits. And we divided the visual analog scale, again, 0 to 10, into either no itch, which is 0, mild itch, which is 0.1 to 3.3, moderate itch, which is 3.4 to 6.6, and then severe, which was above 6.7 up to the maximum of 10. And we also looked at the skin disease activity using a validated disease severity tool called the CDASI, which is the Cutaneous Disease and Activity Severity Index. And we've used this now in a number of trials and a number of ongoing trials to look at the impact of treatment and itch in terms of the activity of the disease. So what this is showing you is how much itch there really is according to, well, it turns out that in our population there are many more females than males. And also we have a lot of patients who don't have muscle disease, what we call clinically amyopathic disease. And so this, but I would say what we're going to show you is that there's not a big difference when it comes to the skin in terms of the symptoms and so on, whether you have muscle or don't have muscle, as long if you have the skin. So on the left-hand side, in the figure, what you can see is how many females and how many males have itch. And what you can see is that over half of people that we had in this particular study had what would be called moderate to severe itch. And about equally, 29% were moderate and 22% severe. But that's a lot of itching. Again, over half of people have really a severe symptom of, or moderate symptom of itch. And again, it doesn't really particularly matter. It's a problem for men and women who have skin involvement. If you look at those who have either classic or dermatomy muscle and skin, or those who just have skin, what you can also see is there's no difference in the type of itching that occurs. So that you can see, for instance, with moderate, that there's exactly the same percentage of people who have moderate itch if they have muscle involvement versus those who only have skin. And the same is true for severe. So there's no difference between these groups in terms of the type of dermatomyositis that a person has. So when you have skin involvement, it's significant for many people. And then this is just showing the distribution of itch according to, again, really just a summary of all of the different people on our database, but showing you, again, the whole range. There's some people who don't itch, up to lots of people who have a high itch score. And again, this is just showing you each individual person in terms of their level of itch. So again, this is just another way of presenting the data that was on the previous slide. Now, if we look at the activity score, so that means if you have erythema and scale and how many different areas are involved, you can appreciate that actually there's an increase in the itching as the activity gets worse. And a score, and this is actually probably worse than it looks, because in a score of 20 is already moderate disease. But you can see that there's a correlation, R value, it's in a decent range and with a significant P value, so that what this is telling us is that the worse the rash, the worse the itch. And that makes sense, but this is a way of, again, putting it into a figure so that we understand that if somebody has a bad rash, we have to take it really seriously, and it's likely that itch is a big problem for that person. I don't probably have to tell you that, but so what causes the itch? Well, there's been a lot of work done in other diseases, such as in contact dermatitis or eczema or, those kinds of diseases where there's a lot of itching. And there's been an increase found in the level of IL-31, and that's a protein that can be made by a number of cells in the skin, and it can cause itch in some diseases. So we were interested in knowing whether this particular itch cytokine, itch protein, might be increased also in patients who had dermatomyositis. So we did some studies to try to look at that, and that's been an ongoing effort, and some of it, the data has just recently been presented actually at a meeting, an international meeting in Orlando. But what you can see is that when you can actually target this cytokine, or this protein, IL-31, with an antibody against the itch receptor, IL-31 receptor alpha, you can actually reduce itch in other diseases. So it makes sense to understand if IL-31 is important in dermatomyositis, because as we develop new drugs that might be helpful for itch, is something else to think about. What, can we target that more specifically? But then the other question is, are there drugs that might be coming down the pike that will help itch, and we might want to see the impact of those drugs on a cytokine such as this protein IL-31. So there's actually been a mouse model where they create a model that allows the mice to make too much IL-31. There are ways of genetically manipulating the mice, and what happens is they actually get a rash and loss of hair and some itch. And when the IL-31 is given repeatedly, it also increases the receptor so that there's more receptor for the IL-31 to bind to. And it turns out that there's actually, this is a DRG, it's a dorsal root ganglia, that's actual nerves. And so what can happen is IL-31 can directly bind to nerves, or it can actually stimulate other things that can aggravate nerves indirectly. But no matter what, we know that there are nerves in the skin that can be stimulated and aggravated in the setting of having too much IL-31. And when they inject, the mice that had this too much IL-31 had a lot of scratching, and that changed, that was also a big issue for these, when there was too much IL-31. So in these other diseases, and I'm not going to go through too much complication in terms of all the different types of inflammatory cells that we have in the skin, but in some of the diseases, the cells that make IL-31 are CD4 positive T cells. That's a type of T cell in the skin that's part of your immune system. And it turns out there are lots of T cells in the skin in dermatomyositis, although the type of cell is a little bit different, and the type of T cell is a little bit different than what we see in eczema and other diseases that IL-31 is important in. And so we actually now, with help from the Myositis Association, are trying to understand more about this itch and which cells are making potentially IL-31, and I'll go through some more data. But anyway, this is what we had known previous to our current studies, is that that these inflammatory cells can make IL-31 and seem to play a role when it comes to eczema and other skin diseases that cause itch. So let me move on here. And so that brings me to, is IL-31 upregulated in dermatomyositis? So we've done some studies in the lab where we actually can look at the RNA that makes the protein of IL-31, and we can see, is there too much of that RNA around that's making the IL-31? And so we can do a kind of testing called real-time PCR, where we can actually amplify in a quantitative way the RNA that's making IL-31 and see, is it higher in people who have dermatomyositis. And we were able to do this in lesions of dermato, normal skin in dermatomyositis, and then in healthy skin. We also did some studies where we looked at a biopsy from dermatomyositis and looked to see if we could find IL-31 in the receptor in the skin. And we did this also for lesional skin, non-lesional skin, and healthy controls. And we could see how much IL-31 was there, and by the intensity of binding, and also how much was in the whole area in the skin, which would also be telling us that there was more produced. And then we were also able to actually elute cells out of skin. So you can take a skin biopsy and actually get the cells to come out of the skin, and then you can label the cells and see what kind of cells are there and which ones are making IL-31. So these are the kinds of experiments that we've been doing in our lab. And what this is showing you is that when you look at the RNA in the skin, this is looking at lesional skin, and look at how much with the IL-31, there's increased levels. This bar here is the median level for IL-31. And you can see that it's increased in a skin lesion of dermato relative to a normal non-lesional area in dermato, and healthy control, you can't really find IL-31. So there's a lot of IL-31 in skin. And also we can see that the receptor goes up a little bit also in lesional skin, as well as in non-lesional. So both the receptor and IL-31 seem to be increased in people that we've looked at with dermatomyositis. And then the other thing that we did was to, on the right-hand panel, look at how much itch was there, and did it correlate with the amount of the RNA that's making IL-31. And what you can see is a nice linear correlation, which is a pretty good R value and P value, suggesting that the itching is worse when there's more IL-31 in dermatomyositis. And we didn't really know this before. And so, again, it helps us understand more about why there's itching and also what we might want to think about in terms of interventions or evaluating a protein that could be linked to itch. So then the other thing that we did was we took a biopsy and we were able to label the skin in such a way that we could look at the green cells, which are the inflammatory, the green CD4, which is the lymphocyte we were talking about. And we could also look at the red IL-31. And you can see it's hard to find very many inflammatory cells or IL-31 in healthy control. But when you go to lesional skin, there's lots of these CD4 cells. And some of them are also making, like here, if you look, I'm going to see if my pointer goes in there, but you can see there's red in the middle and then green around. So this is a lymphocyte that's making IL-31. And there's other cells that are clearly making IL-31 that are not labeling green, and they may be a different type of cell. But I think you can see the difference between the amount of red here in the lesional dermato, and on the left-hand side, that there's much less red in the healthy control. And the same thing is true for the receptor antagonist, where you can see lots of red. And this is this area where I'm pointing to, where there's red on the right bottom picture, is in the epidermis, so the top layer of skin. And you can see there's a lot of receptors there for IL-31 that binds the increased IL-31. And you just don't really see it in the healthy control. So there's something very different about IL-31 and its receptor in lesional skin of people who have dermatomyositis. So then we were able to look at the mean fluorescent intensity, which means how bright is the red in the lesional dermato relative to non-lesional and healthy. And so this is just a normal amount of red. And you can see it goes up between non-lesional and lesional. It's much higher. And the two stars that you see in the left upper graph means that it's really significantly different between the lesional dermato and the healthy control. And so this is showing you the intensity, the amount of IL-31 is more in this situation, but also the area of involvement with IL-31, this itch protein, is also higher in lesional dermato relative to non-lesional and healthy. So the intensity of IL-31 is higher, and also this is the fluorescence intensity here, and then this is looking at the area. So no matter how you look at it, and the area is telling you, is there more red here than on the healthy control? And there's more red, and it's more intense, and that's really all that this is telling us. So I think, and the same thing is true also for IL-31. So again, these are different ways of showing that this is correlating with itch and present in the skin. So what can be done to suppress IL-31? And, that's a good question. So I'm going to talk a little bit about some results that we also published that relate to a medication that's being evaluated for dermatomyositis. And what you can see here is, again, IL-31 is elevated in normal dermato skin relative to healthy control on the left. The panel next to that, what is showing you is that when we take cells in culture, peripheral blood mononuclear cells, and we stimulate them and then add this drug linabasum to the peripheral blood cells in culture, you can see that IL-31 gets dramatically blocked at low doses. And so this is very hopeful, because is that maybe telling us something that might be helpful for itch in people who have dermatomyositis. And what this is showing you is that there's a similar effect on IL-4, which is another itch cytokine that we find in some of the inflammatory cells. But you have to add more of the drug in culture. This is a higher concentration, 10 here, to get kind of the dramatic effects that we're seeing at a lower concentration with IL-31 over here. So it looks like IL-31 is very sensitive to linabasum. And also, we don't see any difference in TGF-beta. So in dermatomyositis peripheral blood, there seems to be a big inhibition of IL-31 by linabasum. And so this is very interesting. And so then the question obviously to ask is, well, what happens when somebody who gets linabasum, what happens to their itch? So it turns out, and this is not necessarily linked to that study, but if we look at responders and non-responders, people who get better and those who don't get better, when you look at the responders, what you can see is that there's a decreased IL-31 intensity between the beginning of a study and the end. And when the non-responders, we don't see improvement. And a non-responder is defined by how much better either their itch gets or their activity in their skin gets. So this is telling us, and this is actually looking at itch responders. But you can see there's an improvement, and it seems to correlate, again, with people who got better, that the IL-31 got better. So if you look at this particular study in terms of the patients that got treated, what you can see is the percent area for IL-31 goes down between the beginning of the visit and visit 6. So that means that there's less IL-31 in the skin. And in the placebo group, there was no change. So that's also interesting, because that might imply that for some people, this could be helpful. And then this is also looking at the area percent for IL-31, again, linking the medication between visit 1 and visit 6 for individual patients. And you can see that lots of people got better over time when they got drug, and probably not such an improvement in people who got the placebo. And then if you look at the number of inflammatory cells in the skin of people who have dermato, this is a baseline, again, before getting medication. Get the medication, and then you take a biopsy both at visit 1 and visit 6. And this is showing that there are fewer inflammatory cells at the end of the study than at the beginning. So that's encouraging. And then the placebo group, again, not really a change. And then the right-sided area is actually connecting the dots for individual patients. Again, there's a lot of improvement between in the amount of inflammatory cells in those who got treated relative to the control. So now we look at interferon beta. So why am I showing you this? Is that it turns out that there's more interferon beta in the skin and in the blood of people who have dermatomyositis, and it's thought to be a bit of a driver of the inflammation in the skin. And so here you can see at the beginning of the study and the end of the study, the people who got the drug, their interferon beta, the amount of area that we could bind interferon beta went down. But in the placebo group, to a certain extent, it did. But you can see at least one person that didn't get better. And this is only a small number of people. But these are the kinds of studies that we will need to do to be able to understand how the medication might be working, or how any medication that we test might be working, and the significance in terms of some of the drivers for the inflammation, such as interferon beta. And then also, if you look in the signature, which is, again, looking at the RNA that makes the protein, this is, again, showing even more dramatically, I think, the improvement that we see in the amount of protein, or amount of RNA-making protein between the beginning at visit 1 and how much it drops at visit 6. And if you look on the right-hand side with the people who got the drug, you can see it also went down quite dramatically relative to those who did not get drug. So this might suggest that some of the drivers of inflammation are also improving when we give people this particular medication. So in conclusion, we found about 50% of our patients with dermatomyositis have moderate to severe itch. The severity of itch correlates with disease activity in the skin. And it looks like skin IL-31 is significantly upregulated in dermatomyositis and localizes with inflammatory cells in the skin that are making IL-31. This new drug, which we have just finished a study for, is emerging treatment potentially for dermato. It has to go undergo a lot more testing. But we have shown, at least in some of the cell culture studies, that it downregulates IL-31 in stimulated PBMCs. And we know that improvement in itch after treatment correlated with the reduction in the IL-31 intensity in lesional skin. So we think that that might be a good thing to look for in future studies to see whether there's improvement in itch and correlating again with IL-31. So I think that's my last slide, and I wanted to leave some time that we can have some further discussion about the significance of itch and any questions you might have.
Thank you very much for that information. That is exciting. I know itch is, like you said, it's a huge issue for so many people, and put up there was one slide that long time ago was a picture, and somebody was like, dermatomyositis causes itch, and they're like, itch doesn't really explain it. It's like,
Exactly.
it's not a big enough word. Robin had asked, what is available right now that can help itch? Is there anything available now, maybe over the counter?
Yes. So, well, I would say that one of the reasons I'm interested in trying to study this is that I think we need much better treatments. Right now, we recommend things like antihistamines, at least at night, to help with sleep. They don't necessarily help that well with the itch, but it's something to think about. If there's specific areas that are itching, you can use mentholated products like Sarna, S-A-R-N-A, lotion over the counter. That can be really helpful. And then any of the current treatments that we use now to deal with the activity in the skin, whether it be the antimalarials or immunosuppressives or IVIG, any of those kinds of treatments, if they work for the inflammation, they usually will also help the itch. And so it's important to try to optimize that treatment. But having said that, we clearly need better treatments.
In your clinical testing of the new drug, has anybody reported any improvement in other symptoms besides the itch?
Well, that's why we did a phase 2 trial. It was a randomized placebo-controlled trial to see if the medication would help with many different parameters. Some of them had to do with skin activity, so the amount of erythema and scale in the skin, and we did show a statistically significant improvement in things like skin activity during the rather short course of the study. We also looked at a lot of other quality of life parameters beyond itch that also seemed to track and get better when the activity got better. And so, and I think now I've shown you some of the skin data that also looks like things are improving and correlating with the improvement that we're seeing in some patients who got the drug. I won't say it's going to work for 100% of people. No drug does. But for people that got improvement, it was, it wasn't just itch. It was also often activity and also other aspects as well.
Thank you.
Mm-hmm.
Hey, Dr. Werth. I was wondering, when I was first diagnosed with dermatomyositis, it was done by a skin culture. Would they be looking at similar things, similar cells that you've been speaking about?
Yeah, that's a great question. I think likely what they did was not so much a culture, but actually a skin biopsy.
Yes.
And what they do then is they fix the tissue and they cut sections and look at it under the microscope. And typically they're looking for certain patterns of the inflammatory cells, but other characteristic changes that can happen within the skin. And there's also something called mucin that we can find. And so there are very specific things that we look for that might help support the diagnosis of dermatomyositis. And what we're looking at here is perhaps a little bit different from that. We're trying to take it to a slightly different level.
Yes, thank you.
Let's see. I'm getting symptoms of itch. This is from Valerie, and she's tapering down to 10 milligrams of prednisone. She wants to know, does that mean that the dermatomyositis is about to flare and that she should increase prednisone dosage?
So the only symptom is itch and no redness, then it's a little hard to know for sure. And I think that if the prednisone is just for the skin, it wouldn't be worth increasing it for that symptom, although it may help. And it may also be an indication that other treatments could be added if, as you reduce the prednisone, things start to flare up, then it might be reasonable to think about other approaches in terms of therapy.
Great. Valerie, if you're with us, did you want to add anything to that?
Thank you so much, Dr. Werth, for answering my question. I really appreciate this whole talk, actually. It's not exactly just itch. It's also kind of redness, but then I'm not too sure whether it's eczema-related or dermatomyositis-related.
Yeah.
So that's my whole concern, yeah.
Well,
thank you.
I mean, I would say work closely with your doctor to make sure that, you're addressing your concerns.
Okay, thank you so much.
And it made me think back to when I first really noticed the symptoms. I had a very red face, and I had some scaling on my scalp, but I wasn't itchy at first. The itch came on, and it came on hard later. Is that typical?
There are people who start with the scalp itching and spreads from there. I mean, I think everybody has their way of presenting, but I would say scalp itch is probably one of the worst aspects of the disease. It's very significant and very disruptive for people. It really interferes with their sleeping, their quality of life. But it can happen at any point. It can happen early, it can happen late, or it can, almost like in isolation sometimes. Yeah.
Mm-hmm. Thank you.
We've seen some of the things in the group where, some people will say that, well, if you're experiencing hair loss due to scalp inflammation and itch, to try different, and I know that we've discussed some supplements last time we talked about this, but this is more for the hair loss type stuff.
Yeah.
And I'm wondering if that truly works, if dermatomyositis, if the scalp inflammation and itch and the hair loss is related to the dermatomyositis and not so much supplementing something that's not being produced in your body.
Right. So what I would say is, you're probably referring to things like biotin that people take for alopecia or hair loss.
Exactly.
And that is probably not going to be super helpful in dermatomyositis, because the reason the hair is falling out normally is because of the inflammation in the scalp. And so you kind of need something that's going to control the inflammation, which is causing the hair loss. Often when you get rid of the inflammation, the hair is going to grow back just because the inflammation is gone.
Okay, great. I can relay that. Thank you. Linda?
I no question so much, or I have very specific itch starting areas. It's hard to explain. There won't be any redness, just certain areas. Like there's a patch near one of my ankles, and on the other ankle it's the other side. And I've been trying to really keep track of it. I definitely am noticing a correlation to when that starts. There's usually a flare coming, and the muscle weakness comes not long after. We're still figuring out my cocktail. Mm-hmm. I've used cortisone cream. I mean, I try to use, coconut oil or something else, but when it's really bad, I do use cortisone cream. Is that a not great idea? Is that an okay thing to use?
Yeah, no, I think you bring up a very good point, which is if it's a very localized itch, then a topical steroid can be very helpful. And it probably wouldn't be necessarily the over-the-counter variety for an ankle. You might use something a little more medicated, more fluorinated steroid topically, like the ointment or a cream, and that can be really helpful sometimes. There are different formulations for the scalp. There are liquids and foams that you can use, and there are also other anti-inflammatory drugs, pimecrolimus and tacrolimus, that are used topically that can also be helpful for the itch and for the inflammation.
Thank you.
Now I have a more complicated scenario on this one. So it's a skin biopsy that read acute and chronic lymphocyte-mediated vascular injury phenomenon associated with prominent deposits of C5b9 within microvasculature suggested that the effector mechanism of endothelial cell injury is in fact C5b9. The question there is, what is C5b9? If there's an easy answer for that.
Well, no, it's a pattern that we see on immunofluorescence in the skin when you look for complement, and it's part of what we call the terminal complement pathway, which is part of the inflammatory pathway that can go on in the skin and elsewhere in the body. And you get deposition of this complement activated product in the vessel wall in dermatomyositis, and it's actually one of the tests that sometimes is used to differentiate lupus from dermatomyositis. And, not that it's done all the time, but it can be helpful. And it's telling us something about the way that the inflammation is setting up in the skin, that it does seem to target the endothelium and the vessels a little bit more than some other diseases.
Very interesting. Continue to learn new things. Danielle says, thank you. I'll ask one question. I do notice that sometimes, just me personally, I may not have any type of redness or, I just sometimes just itch kind of everywhere. I know that could be a ton of different things. I didn't know if that is something that's commonly reported with dermatomyositis.
I mean, just having itching all over.
Just kind of like my face will start itching for a little while, or my arm, or and there's not really like any scale or rash, so to speak. Just kind of happens.
Well, people have shown that there is a little bit of a disconnect. Like, you don't have to have erythema to have itch. And the cytokines, I think, very often, if you can block the itch cytokines or the proteins, you can actually still have the redness but not have the itch. And so I think that probably it's just that your nerves are twitching a little bit from the proteins that are simulating the itch, and it can kind of move around a little bit. So I'm not surprised. I mean, as you can see, we have found in the blood that you can stimulate IL-31, and that can be circulating around, and it can be in the skin and cause local problems in different areas.
Great, thank you. And I think what's so exciting, and she hasn't really said much because this drug still is in research studies and clinical trials, is from everything that's been shown so far, the safety profile of this drug is amazing. The side effects seem to be very, very limited as opposed to the stuff that we're being prescribed now. It's not an immune suppressive type drug. So it's a lot safer. Hopefully it'll work out for us. It'll be a lot safer treatment.
I haven't been able to do some clinical trials because I'm on Plaquenil. So for this particular remedy that's coming out, will there also be some gating factors that would prevent people from being able to take it?
So it really depends on each individual protocol as to what medications are allowed or not allowed. In the study that we completed, people could be on Plaquenil. In fact, they had to pretty much either not tolerate it or not respond to Plaquenil in order to get the drug. And many people stayed on Plaquenil during the trial and didn't cause extra problems in terms of tolerating the drug. So I think, usually most studies are able to allow some background therapy so that it doesn't knock you completely out of being able to participate in studies. And I do think the emphasis on participation as we try to get better drugs is very, very important, because it's really can only be done in a partnership between the patients and the people that are trying to run the trials.
Yes, and we look forward at MSU to being able to help provide some of those patients when you start looking.
Right.
We have direct access to a few thousand patients with DM, so we can reach them directly, sometimes in real time. So hopefully we'll be able to help you guys, get the amount of patients that you're looking for.
Yeah. That's very important and very helpful.
Yeah, we've tried to promote that in basically in the groups to let people know, patients need to be willing to participate in order for things to move forward. So
yeah, there are a lot of benefits being in studies, and if they're well run, then you can really, I think there are a lot of benefits to it.
Absolutely. Did you have anything you wanted to add, Dr. Werth?
No, it's really great telling you about some of the new data that's coming along, and we're excited about continuing to pursue this in the future.
We really appreciate you taking the time to join us, and we welcome you anytime.
Thank you very much.
Thank you.
Thank you.
We would like to once again thank Dr. Werth for joining us today for new developments on the role of itch in dermatomyositis. For more information about myositis support and understanding, please visit us online at understandingmyositis.org.